It is also acute. Just patient will complain or will tell you that just in the morning or from yesterday he is having watering and some foreign body sensation. So if you do exam on the torch examination or slit lamp examination.
पहिले स्लाइड पर पहिले बसून जावं लागलं असं ना
कार्यक्रम होता पण त्यानंतर आपण लेक्चर घेतलं ना.
नाही आता आज आणल्यावर कुठे घेतलं
नाही 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 आज नाही हो. हे नव्हतं का आपलं काय म्हणतात त्याला. हे कधी होता कार्यक्रम.
हा त्याच्यावर चालतं ना पण आज ते थोडं
वाच केलं करून दे
ना. Good morning students. Today we will discuss a case in which there is a female of 50 years old complaining of watering from right eye. So we have to discuss what are the causes, what is the differential diagnosis of this case. So common causes for unilateral watering are foreign body in the eye, conjunctivitis and chronic dacryocystitis. Now among these, foreign body in the eye is very common condition. Generally and histories of just one day, because a person cannot remain for long days with the foreign body, and there will be lacrimation, excessive watering, and this is a natural phenomena to flush the foreign body. So if you see on torchlight or slit lamp examination, you will detect the foreign body in the eye. And after removal of the foreign body, means you have to remove the foreign body. How you will remove? Put the this local anesthetic like 4% as halocaine, and then you can remove the foreign body. And immediately after removing the foreign body, irritation will be stopped and watering will be stopped. Then conjunctivitis, another cause is conjunctivitis. Actually conjunctivitis is a bilateral condition, so watering will be from both eyes, but sometimes it happen in initial condition one eye is more involved than other eye, and may happen that watering from one eye only. So at that time when you see, then there will be no foreign body, but there will be conjunctival congestion in the fornix. You will see that there is a conjunctival congestion, but you have to rule out this foreign body in this also, and then you have to give the antibiotics, and then immediately after some time, means on the same day, patient will get relief from this watering. So this is about the conjunctivitis. Then chronic dacryocystitis. In chronic dacryocystitis, you know, regurgitation test. We do the regurgitation. How we do the regurgitation test? We just press with the index finger over the lacrimal sac area, and you will see that after pressing there will be some discharge. Then we call it as a regurgitation test positive, and if regurgitation test positive, then it is labeled as chronic dacryocystitis. So in this way you can differentiate foreign body, conjunctivitis and dacryocystitis. So what is dacryocystitis? You know, dacryocystitis is a inflammation of lacrimal sac, and in this patient gives watering or history of watering or mucoid discharge of long duration. In foreign body or conjunctivitis, generally history is acute of 1 day or 2 days, but in this case patient will give history of watering since 2 months, 3 months like this. So it is of long duration. Then there may be history of swelling in sac area, Sometimes there will be swelling in sac area. Patient will tell you, if you'll ask the patient whether there is a swelling on that area, he may give positive history. And then yeah, you can do sac syringing. But before that, you have to differentiate that whether it is a acute dacrocystitis or chronic dacrocystitis. In acute dacrocystitis, there is a severe pain, then a swelling in that area, and patient will not allow to touch in the sac area. So you cannot do the regurgitation test also. And sac syringing also you cannot do. So in acute dacrocystitis, you have to just give the systemic antibiotic, local antibiotic, and anti-inflammatory to the patient, and with that patient will get relief. And after that you can call patient for review, and then you can consider management of chronic dacrocystitis. So in chronic dacrocystitis, you can do the sac syringing. So in sac syringing, you know how sac syringing is done. You have to put the local anesthetic. Then there are punctum, there is upper punctum, lower punctum on the eyelids. Then you have to dilate the punctum, and then with sac syringing cannula, which is attached to the syringe containing normal saline. So normal saline is pushed through the punctum, and you will see that normally the fluid goes into the throat, and patient will tell that some fluid is coming in his throat. But in if there is a dacrocystitis, fluid will not enter into throat, but it will come out through the upper punctum, maybe same punctum. If it is coming from the same punctum, means same canaliculus block is there. If it is coming from upper punctum, then block may be in the sac, maybe in the nasolacrimal duct. So in this way, you can diagnose a case of dacrocystitis, or in some condition dacrocystography may be required. So especially in cases where there is a fistula formation. What happens many times, patient do not come to the doctor for long time, and there is a lacrimal abscess, and that will rupture, and that will burst, and there will be first formation of fistula formation, and there can be multiple fistulae also. So while operating, while doing the surgery of lacrimal sac, we have to trace out these fistulae. So in this case, you have to do the dacrocystography. In dacrocystography, then you will come to know where is the block, then if there are fistulae, they are also detected, and according to that you can manage the case. Now in chronic dacrocystitis, then the treatment is surgery. Treatment is the surgery. In acute dacrocystitis, the medical, but in chronic, surgery has to be done. So which are the surgeries in relation with the chronic dacrocystitis? These are DCR or DCT. DCR means dacrocystorhiноstomy, and DCT means dacrocystectomy. So how to decide whether to do the DCR or DCT? Generally, in a young patient, we prefer the DCR, because there are many advantages in doing the DCR in young people. One thing, cosmetic purpose. Another thing, sac is a bigger one, you can do DCR very well. But in old age, you cannot do DCR because sac is atrophied. Actually, surgery is a DCR because you have to maintain the lacrimal passages. There should be natural drainage of tears, and that can be done only in the DCR, dacrocystorhiноstomy. Dacrocystocystomy lacrimal sac. Rhinostomy means you are communicating lacrimal sac and nasal cavity. So you are forming a alternative pathway for flow of the tears. So means recommended surgery for dacrocystitis, DCR. You should not do DCR, DCT because you are removing the sac in the DCT. So there will be no drainage of the tears. So you should prefer only dacrocystitis until there is a contraindication to the DCR. So in DCR also there are two types. One is endonasal and another is external DCR. So endonasal DCR generally it is done through the by endoscope, and in this by endoscopy this passage is made in the nasal cavity, but in this the passage is not maintained for long time. There are chances of blockage of this passage because you are not suturing, and opening is kept as it is. That's why failure rate is more in the endonasal, but the procedure is of short duration. Again, there cosmetically there is no scar on the sac area. That's why in young people they prefer the endonasal. While in external DCR you have to take the incision on the sac area, and after healing there will be a scar. And again, external DCR you require more time, but success rate is more in external DCR because you are making a passage and you are suturing, so that passage will remain open for long duration. That's why success rate is more in the external DCR. So mainly we will discuss about this external DCR. You might have seen during your posting, many of you might have seen the procedure of external DCR. So what are the steps in external DCR? First, you have to find out, you have to decide whether you have to do the external DCR endonasal DCR. Then the already preoperative preparation, that you have to put the antibiotic drops for 1 day. Then 1 hour before the surgery you have to pack the nasal cavity. One more point I have to tell, one point is missed, that you have to rule out the conditions, contraindications for this DCR. Means there should not be DNAs, or if there are polyps, means blockage of the nasolacrimal duct can be there, and that you have to treat, and that then you can go for this DCR. So all the nasal causes you have to rule out, and then you have to go for the DCR. So for that you have to pack the nasal cavity with gauze soaked in 2% halogen jelly, and this nasal packing is done. Then patient can be shifted to the OT. Now this external DCR, it is done under the local anesthesia. So infiltration of with the local anesthesia is done in the sac area with the 2% halogen, adrenaline, high adrenaline in that area. And then after confirmation of anesthesia in that area, you can proceed for the surgery. Now a hockey stick incision 3 mm away from medial canthus is taken with the blade, and then subcutaneous tissue is dissected, separated out, and lacrimal sac is exposed. Generally lacrimal sac lies under the medial palpebral ligament. You see the medial palpebral ligament is a transverse white band shining running horizontally. It will be seen after the blunt dissection, and then this medial palpebral ligament, some surgeon they cut, or some surgeon do not cut that band. So that is a very important anatomical landmark, because immediately below the medial palpebral ligament there is a sac. So you can identify easily with the help of this medial palpebral ligament and typical color of the lacrimal sac, you can identify the sac. Then after exposure of the sac is separated, its medial surface is separated from the lacrimal fossa, and then you have to make an opening in the lacrimal bone. So for that, lacrimal bone is, if a tissue is attached over this lacrimal bone, you have to clean out that, because that tryphin you are using for making a hole should not be slip. So with patiently, that tissue from the lacrimal bone is removed. Then hole is made, a cavity is made in the lacrimal bone with the help of tryphin. So with the tryphin, it is a slightly crude method, but it is possible with the expert hand. It is a smooth opening in the lacrimal bone. So as lacrimal bone is open, a circular disc of the lacrimal bone is taken out, sufficient size. It is, if it is not of sufficient size, it is made of sufficient size with the bone punch. A little finger should be pass through that opening, so it indicates, that is the test on table itself, that to detect or to know whether opening is of sufficient size or not. So when surgeon comes to know that it is of sufficient size, then incision are made over the this nasal mucosa. Now when lacrimal bone is removed, there will be nasal mucosa will be exposed. Now nasal mucosa is exposed, lacrimal sac is exposed. Now you have to take the incision over these areas. One incision over the medial surface of lacrimal sac and another is nasal mucosa. So on medial surface of lacrimal sac, inverted U-shaped incision is taken. Same with the on nasal mucosa also, inverted U-shaped incision is taken. When you take incision over the nasal mucosa, there is a severe bleeding, and you can stop with the spraying of the adrenaline or by pressure that bleeding. Then as flaps are made with the help of this inverted U-shaped incision, then these flaps are sutured. These flaps are sutured. So as these flaps are sutured, there are less chances of closing this opening or passage which you have made. The passage running from lacrimal sac to the nasal cavity. This passage will be remain open, and that is the success of this external. That is the, due to this suturing, external DCR is successful than the endonasal. So suturing of this flap is done, and then suturing of this remaining whatever wound you have made, that suturing you have to done. In this way, wound is closed. So this is a DCR. In this we are making alternative passage. Now this passage is in the nasal cavity, but in the middle meatus. Our natural opening is in the inferior meatus. You know, nasolacrimal duct opens into the inferior meatus. Now this opening we have made is in the middle meatus. So now the communication of the lacrimal sac instead of inferior meatus is into the middle meatus. Then DCT, dacrocystectomy. In this way, just you have to expose the sac as we have exposed in the DCR, and just you have to fix the sac, hold with the artery forceps, and then by approaching toward the base of the sac, you have to remove the sac. In this way, lacrimal sac is removed in the DCT, while lacrimal sac is kept as such, and it is communicated with the nasal cavity in the DCR. So natural passage of drainage of tear is maintained in the DCR, while that is not maintained in the DCT. That's why after DCT also there will be watering from the eye. But now the infected focus we have removed. So whatever the watering will be, there will be clear watering, means there will be no muco discharge, or there will be no formation of mucosa, no pus discharge will be there. Clear watering will be there, and which is not harmful. Means if dacrocystitis is not treated, there will be constant source of infection, and if immunity is low, cornea may be involved. There may be corneal ulcer also, and you know corneal ulcer is a dangerous condition. Means there is a formation of corneal opacity, and that will affect the vision, or it may lead to the perforation. So in this way, patient can lose his eye. That's why treatment for dacrocystitis is very important. Again, one more, if the patient is having cataract, then you have to first remove this infected lacrimal sac. In this, preferred surgery is DCT, because infected focus should not be there in the cataract. That's why many surgeons prefer DCT instead of DCR if patient has to go for the cataract surgery. So one point that in old people the sac is atrophic, that's why DCR is not possible, and you have to do the DCT only. Then post-operatively, you have to give the systemic antibiotic, local antibiotic, and then you have to give a local pad, and then on second day you can remove the sac pad and see whether there is a swelling or any hematoma formation. And in DCR you can see the patency, means you can do the sac syringing. You may do with the using fluid as a routine sac syringing we are doing, or some people they inject the ear to see the patency of the this lacrimal passage. So in this way, this DCT and DCR done. Then antibiotics are given for the 7 days, and then after 7 days sutures are removed if there is no gaping. So in this way this dacrocystitis is managed. So we have discussed a case of a young adult or 50 years of a female having watering from one eye. So causes were discussed, generally foreign body, conjunctivitis and dacrocystitis. We have seen after removal of the foreign body, watering will be stopped. In conjunctivitis, after taking local antibiotics, also watering will be stopped. But in dacrocystitis, regurgitation test is positive and you have to manage the case. If chronic dacrocystitis, with the help of surgery, and if acute dacrocystitis, initially you have to give systemic antibiotic, anti-inflammatory drug like combiflam, and after disappearance of this swelling, pain, and near about after 15 days you can advise lacrimal sac surgery. Okay, thank you.
तुमचं काढून द्या ना ते पेनड्राईव्ह काढून द्या पेनड्राईव्ह तुमचं काढून द्या
हां.
काढा बघू
Sir,